Vinod there or is Vinod there?
Mm, No, sir.
Hello?
And no, sir. Vinod is not there, sir.
I think the four of them and no um, four of you and Nitya. Okay, right. Sameer, start man.
Good evening, everyone. I'll be doing the ward rounds. Yeah. So, a 73-year-old male came with complaints of on and off abdominal pain since 2 months. The pain was intermittent in nature, more over the epigastrium, and it was non-radiating, relieving partially with medications, and it was not associated with food intake. And there was also complaints of yellowish discoloration of eyes since 4 days, which was initially noticed by the family members. But patient had no change of color of stools or urine, no history of pruritus. So, past medical history. Patient was initially admitted 4 months ago in view of acute cholecystitis in outside hospital, and he had no history of unintentional weight loss or decreased appetite. He was a known case of hypertension and diabetes mellitus. Coronary angiogram patient underwent 7 years ago and was on tab clopidogrel 75 mg. No known drug allergies. So his general examination was within normal limits, and vitals were also normal. Abdomen was soft and non-tender. Local examination, there was left inguinal only cough impulse with no visible herniation seen.
Okay, now you stop here.
Yes, sir.
Praveen, what do you think is going on?
Uh, as in the past history and the abdominal pain was recurring, might be the acute calculus cholecystitis might be gone into complicated, sir.
What complications likely?
Like gangrenous gallbladder.
Why gangrene suddenly?
Sir,
Why are you thinking of gangrenous gallbladder?
sir, the stones might get stuck at the neck and.
No, I'm not
Yes,
talking
sir.
about this one. What are the clinical features in history and examination that you think he might have gone to gangrenous gallbladder?
Sir, he has recurrent abdominal pains, sir.
Yeah.
Since
Pain
2 months.
alone will
And
not
a
say
fever, sir.
gangrene. He has no fever. I don't think he mentioned fever.
No,
Okay,
sir.
so I see you should not, see, gangrenous gallbladder it cannot be made as a clinical diagnosis. How can you make a clinical diagnosis of gangrenous gallbladder? You can say acute cholecystitis. You can
Okay,
say if the gallbladder is become very big and palpable and tender, you can say empyema gallbladder. Or if it is non-tender and gallbladder palpable, you can say mucocele of the gallbladder. You can't make a diagnosis of gangrenous gallbladder clinically.
yes, sir.
Nikita, what do you think is going on?
Sir, Niranjan sir has also joined, sir.
Yeah. Good evening, Niranjan.
Good evening, sir.
Sir,
Ah,
sir, it could be two things, sir. One is because the recurrent episodes might suggest that there was some calculi which were passing off. Right now, it could be passed off, and he's feeling no pain and abdomen also non-tender.
No,
The
sir.
other thing,
Sir, I had one doubt. Was it acalculous cholecystitis or cholecystitis previously? He said
calculus.
acalculous, if I remember. He
Yes,
Yes, sir,
show
sir.
calculus.
go back. Samir, go there.
It was acalculous, sir.
Huh?
It was initially acalculous, sir. When he was admitted in that other first hospital, they had diagnosed it acalculous only, sir.
Okay. Then now, why are they talking about stones now?
It could be passed off, sir.
Highly unlikely for acalculous
Yeah.
cholecystitis to present with passed off stone as acalculous cholecystitis. Whenever
Yeah.
acalculous cholecystitis is there, it is usually viral or some part of polyserositis. Or
Or
viral.
there is a severe illness For example, patient not having eaten, for a long time, or typhoid, any severe illness, preceding the illness, this one, then or patients on TPN for some time. So such only in such clinical situations you should think of acute acalculous cholecystitis. Otherwise, what Niranjan said is right. Suddenly, somebody who has got stone was passed off, and then recurrent episodes of acalculous cholecystitis is unlikely.
Maybe
So
an incomplete evaluation might have been done, sir.
yeah, that you can
Probably.
say.
Probably. Yes, sir.
But
Second thing could
most,
be,
huh,
yes.
considering his age, as anyone talked about loss of appetite, loss of weight, and all these things,
Yes, sir.
Yes, sir.
because
They were taken into
jaundice
account.
with so jaundice and pain, I agree. If it is related to gallbladder, it may not be pain. It may be painless, but it could be something else. For example, you have carcinoma of stomach or carcinoma of the head of the pancreas, which is causing the pain because its posterior lesions can infiltrate the thing and cause pain, and then the jaundice also. So you can't just at 75. You can't, especially if you have not had any evidence, to straight away just say only gallbladder related problems. Of course, that is one of the things, but you have to have an open mind about it being something else. Niranjan, anything to add?
Nothing, sir. Same.
See that you can't go on one track and say it is just stone that has passed or whatever. So, and clinically, this one, Nikita, all of you, please remember, you can't make a clinical diagnosis of gangrenous gallbladder. It is only when you operate you will know that it is gangrenous. Even, for example, if on CT or ultrasound, if they find gas in the wall, only then they will comment. But I haven't seen any, for number of gallbladders that we have seen, I don't think anybody has reported it as gangrenous gallbladder radiologically. Okay, carry on, Sameer.
Yes, sir. So this was the initial blood reports which patient came with to the emergency. The counts were almost within normal limits. The hemoglobin was 13, and LFT, the bilirubin was initially increased with 1.51, and direct was 0.36, and there were elevated liver enzymes, and renal function test within normal limits. Also, the
Okay,
patient, yes, sir.
yeah.
The
With
patient
this, wait,
came,
wait, go back, go back.
sir.
With this, Nikita, what investigations will you get done?
Sir, I would like to repeat the total counts and LFT again, sir.
No, why? It is already been done on admission. This is a new one. When I think
Same
these
day,
are
sir.
figures on admission, no?
No, sir,
Same
they had
day.
already came with these reports done outside on the same day, sir.
Huh. Yeah, you can repeat it. Okay, you'll repeat CBC.
And yes, sir, amylase lipase also, sir.
Hmm.
But clinically, patient has no pain. That's one of the parameter.
No, but I think he said he has pain, no? That is what one of the
He
presenting
had
feature,
pain, sir.
presenting features was pain for a few days.
Yes, sir. Yes, sir.
Hmm.
But on the day of admission, there is no pain.
Hmm.
But even then, serum amylase and lipase,
Okay. What else?
uh, will get an ultrasound done, sir.
Ultrasound.
Could be
What
the
do you
current
expect in
situation.
ultrasound? What do you
Sir,
expect in
we'll be
ultrasound?
looking into the gallbladder,
Hmm.
CBD, as well as pancreas, if there is any comment, sir.
Hmm.
Mainly,
Samir, what are his symptoms for how long is the symptoms going on for? Now 7 days, is it? Pain?
Yes, sir. The recent pain was with 4 days, sir, actually. Yeah.
4 days.
Yes.
Okay, right. Okay, ultrasound. Put up the ultrasound report.
Yes, sir. So this patient came with this report. It was irregular hypoechoic lesion in the liver anterior to the gallbladder of 6 centimeters. 6 into 3 centimeters, and there was a focal discontinuity in the gallbladder wall suggestive of invasion. And CBD was 6 mm with no calculi. The USG, the final impression was suggestive of neoplastic etiology. Also, in the same setting, patient underwent a CT scan which showed acute gangrenous cholecystitis with perforation with abscess in the segment 4 and 5, and same irregular hypoattenuating lesion in the liver with no calculi in gallbladder. And they also had reported as like acute gangrenous cholecystitis, query neoplastic etiologies.
Cori neoplastic. Okay.
Yes.
Right. Now, Praveen, how are you going to proceed with this patient?
Sir, I'd like to do MRCP, sir.
What will MRCP give you? MRCT is already given you all the information. Ultrasound does not show any dilated CBD. The liver functions are relatively normal. Nothing to worry about. Why are you going to do MRCP?
The cause for gangrenous cholecystitis, sir.
But how will MRCP give you the answer? CT would have given you the answer. No?
MRCP gives clear IHBD, intrahepatic biliary ductules.
I'm not sure whether MRCP is going to add anything to your, the information that you already have. Niranjan, did you get an MRCP done?
Hello? Sir, I don't think MRCP will help in this case. Already there is a perforated gangrenous gallbladder with abscess formation. So I don't think MRCP is going to add anything into this diagnosis.
Correct.
And CT has already been done. So whether stone is there or not there, you have to operate.
Operate. So you can, if at all, there is something that you can do, which is something that we have been doing recently. Nikita, what would you do in this patient?
Sir, we can do an endoscopic ultrasound, sir, because the ultrasound and CT are suggesting there is something else other than the gallbladder pathology.
Yeah,
So
but
to have
Why,
a clear
why will you want to do an endo ultrasound when there is a acute gallbladder with perforated gallbladder with abscess? How will that endo ultrasound help you?
Yeah,
sir,
with respect to
they were
diagnosis or
also
management?
commenting on the hypoechoic lesion, no, sir.
Yeah, more than that, I
But
would have asked you something else, which we have been doing recently. What, the information that Praveen wanted, you can get it by doing something else. What is that? Praveen, your paper man, what are you going to do?
ICG, sir.
I think it may be something that in ICG that you should consider in this patient. Give endocyanin green so that on the table it may help you to see, delineate the CBD and, as you said, the cause for gangrenous gallbladder. All those things may be evident by doing an ICG cholangiogram. But
Nikita, even if it is malignancy as you're suspecting, endo ultrasound will not be able to confirm anything in that. So when there is an abscess and also a gangrenous gallbladder, it is better to do, because even if it is malignancy, it's already metastatic because it is perforated. So whatever it is, you have to do a diagnostic laparoscopy. Even if it is suspecting malignancy, then you will have a diagnosis and also possibly a biopsy. And also you have to drain the abscess.
Yeah. So,
but sir, as patient vitals are stable and all, can't we evaluate further before proceeding?
How will
sir?
it help? How will it help in your management?
Evaluation? What further evaluation, ma Nikita? Yeah. Go ahead. Tell us what else you want to do.
So we'll repeat the LFT once again, sir, to see the progress of the enzymes, because enzymes were also elevated.
LFT
No,
is
but
not
enzymes can be elevated in
marginally.
sepsis also. It is only SGOT, SGPT which is grossly elevated compared to GGT. and then there is no extra like IHBR dilatation or CBD dilatation on ultrasound as well as CT. So by doing a repeat LFT, how is it going to help? And that to the same day.
But same day, actually, sir, it's not exactly same day, sir. Patient was admitted in the evening of the previous day,
Hmm.
and we had the reference next day morning. So the
Correct.
LFT was done somewhere around the afternoon of the previous day,
Oh,
probably
correct.
No,
But
within
how is
24
it
hours
going to,
only.
like,
Yes,
how
sir.
is it going to alter your management by repeating an LFT? If it is
Patient
due
is
to
always,
sepsis, it will may stay the same or it might go up also.
sir, clinically also he's not in sepsis, sir, because of there is no increased heart rate, there is no fever episodes, TLC is normal.
okay,
Patient is
okay.
a
So
diabetic, no?
yes, sir, diabetic.
So in diabetics, as you know, the response will not be there. Even if it is gangrenous cholecystitis, TLC might be normal. Is their pain perception also might not be very severe.
Nikita, I am
Yes,
not able to understand the logic of repeating LFT in just in 24 hours. Just tell me, how is it going to affect your management? Just,
no, no, sir, by
delineate. Ah,
because enzymes are elevated, we were suspecting some obstruction in the CBD, sir. Not exactly calculate, but it could be sludge. So
ah.
we were thinking, like, if to rule out the obstruction, then plan for the surgery, sir. That was the point.
No, but see you have ultrasound and CT both have actually very clearly told you that CBD is not dilated, and the bilirubin, direct bilirubin is very marginal. It's not, no, it's not conjugated hyperbilirubinemia. The alkaline phosphatase GGT is not that elevated. So I don't think there is currently any evidence to suggest that this is obstructive jaundice due to sludge or whatever. I
And
think
even with your argument, patient then should be going in for cholangitis if there was obstruction. Total count
Ye-
should be high and bilirubin should be rising. Patient should be having fever with chills and all those things.
so.
Yes, sir. It
In,
could
in
be
the
passed off.
exams, in the exams, if you argue like this, you are going to get into trouble because you are
Yes.
not able to substantiate what you are saying.
And
So,
also, if it is, as you're saying, passed off stone, there has to be probably transient rise of amylase lipase also. That is also
and
not there.
and CBD should be dilated because when the stone is in the CBD and then it passes, it won't collapse immediately. There will be some dilatation of the CBD.
And also some evidence of probably pancreatic, peripancreatic fluid and all that. Whenever there is a passed off stone with severe acute presentation.
Right now, what is done? Next slide.
Yes, sir.
Sir, one doubt, sir.
Ah,
As they were suspecting malignancy in the same sitting CT, we can have done CT guided biopsy, sir, for liver lesion.
No,
see,
but you
when
have
you
to
are,
go
it
CT
for,
is a
was,
perforated gallbladder, right?
yes, sir.
No, this one, Praveen, is it a perforated gallbladder?
Yes, sir.
Have they reported it as gangrenous gallbladder on
Yes,
CT?
sir. Yes, sir.
So, whether even if it is malignancy, you are duty bound to remove that gallbladder, right?
Yes, sir.
You can't leave a gangrenous gallbladder inside,
Yes, sir.
correct?
and how is it going to change your management?
And so then when you are doing the thing, if you see a lesion laparoscopically, then biopsy it instead of how is doing a CT guided or ultrasound guided biopsy of the liver going to change your management. Always, I know you need to get a diagnosis, but always look at it from how you are going to manage the patient and what investigations are going to help you to make that decision or change your decision. So ultrasound or CT guided biopsy is not going to change it. Is it going to change it? Are you going to say it's already malignancy, so I won't do anything? I leave a gangrenous gallbladder alone inside the abdomen?
No, sir. No immediate change it is.
So the management will not change. If, for example, ideally you do a diagnostic laparoscopy, take out the gallbladder. If you see a lesion, take biopsy laparoscopically. If you can't see the lesion, if it is deep inside, then post-operatively when the patient gets better, get a ultrasound or liver, a CT guided biopsy.
Okay, sir.
No, always, you should be logical. Okay. carry on, Sameer.
Yes, sir. Sir, one thing is, I went through his old report, sir.
Ah,
In this 3 or 4 months, he was admitted multiple times in hospital, and
ah,
CBD was reported to be somewhere 9 mm, somewhere it will be again 6 mm, again 8 mm.
ah.
So that was one thing, sir.
Okay.
Yes, sir.
So what do you think? What do you
There
think
was
might be going on?
the dilated CBT was there, sir, earlier, and
Ah.
I don't know how this
So,
ultrasound will differ.
so what do you think might have happened? Anybody?
Sir, recurrent obstruction, sir,
Due to what?
either sludge or any mass pressing onto the CBD.
See, I think it could be a stone that has passed. So, or it could be intrahepatic cholangiocarcinoma, where the tumor might have sloughed off and the CBD was dilated and then it sloughed off and CBD is collapsed again. You know, it's possible. That is the one. Those are the two possibilities: sludge or stone, or intrahepatic cholangiocarcinoma. Okay, carry on.
Yes. So
Sir,
that this one.
here before the start of discussion, sir,
Ah,
we actually got the reference from the patient to the surgery with the repeated LFT. That is the point which confused us more,
ah,
sir. So repeated LFT
ah,
value was bilirubin was elevated and direct bilirubin was also elevated.
ah.
That is the
How much?
point where it
What?
confused it from sepsis to the obstruction. So
So
we
what?
were
What are the
thinking of
values? What are the values?
So it was around 3.5 total
Yeah, plus
bilirubin,
here, sir.
which was
3.5 and enzymes were further elevated, sir. So this is what confused us to
Ah,
think about obstruction more before management, sir.
yeah, yeah. Alpha. This is elevated, correct?
So this
So,
is the next day morning values.
ah,
Yes, sir. Here the MRCP they told this pancreatic duct was prominent and CBD had no calculi. Radiology said they suggested contrast to rule out malignancy, sir.
Sir, but with these LFT values, should we actually consider an MRCP, sir? Because of these LFT values only, we did MRCP. But will it mandate or can we still proceed with the lab coli, sir?
I think if these values are there, I would consider doing a MRCP before doing surgery, because the first reports were not, this prominent, but now you can see both GGT and alkaline phosphatase is very significantly elevated. So you need to have a roadmap of the biliary system. Certainly, I would do an MRCP with this report. Did you do it?
Yes, sir. We actually did MRCP, but that was the point of discussion, sir. Because
Ah,
from the practice team, we were asked to go ahead with the surgery, but
ah,
we wanted MRCP, sir.
ah.
So how should we tackle the situation? Uh, should we actually accept the directly going into lab coli? Is it reasonable? Was the question, sir. If the
Where is
pressure
the
is on us,
MRCP pictures you have?
sir, this is MRCP picture, sir. The right side one.
No, but
Right
where
side
is
is
the
MRCP. Left side
no,
is
no.
CBD.
Yeah, but I want the CBD, the biliary system, biliary tree. Where is that? Usually, you have a
Sorry?
reconstructed view of the biliary system, no, showing
Yes,
both the
but
CBD, pancreatic duct, and everything. You have that?
biliary tree was fine, sir. No deficits noted. Biliary tree was fine, but the liver lesion and the gallbladder invasion were seen here.
Pancreatic duct also was prominent.
A little prominent, sir.
Niranjan?
No, with such a background of LFT rather than MRCP, I would have probably gone ahead with endo ultrasound and SOS, this thing, ERCP or whatever. If LFTs are raising so much, rather than MRCP, because again, MRCP, if they've said there is no stone or something in the CBD, and CBD doesn't look that grossly dilated here. So, and that lesion looks more like probably an abscess extending from the gallbladder.
Hmm.
Was there a stone at the neck of the gallbladder in this picture? Second picture?
No, sir.
What is that round thing in the neck region?
Looks like lymph node, sir. That was lymph node only, sir.
Lymph node.
This one.
Yes, sir. The white circle at the beginning of the gallbladder.
Yeah,
This
neck
one.
neck of the gallbladder. That
Yes,
one,
sir,
yeah.
yes. That
What
was
is that?
lymph node only, sir.
Lymph node.
Yes, sir.
They have commented as lymph node.
Yes, sir.
Okay.
Prominent
But it
lymph
is-
node they had mentioned, sir, reactive.
No, but it seems to be intraluminal into the.
Correct. It looks like it's inside the gallbladder rather than outside the gallbladder.
No, sir. Wall was thickened a lot, and
No,
that
no.
was
That
on
lesion,
the wall.
whatever you are showing, it appears to be inside the wall of the gallbladder rather than outside.
No, sir. That just maybe this frame looks like that, but it was just a lymph node, sir.
Okay. Anyway, now with this thing, I think there are a lot of confusing issues. Can somebody tell me why there is all this confusion?
Sir, what confusion, sir?
There will be a lot of confusion, no, whether we should do repeat
Hmm.
LFT, MRCP,
The problem was, sir, patient was admitted under nephro team as primary,
Correct.
and they explained the patient attenders that tomorrow surgery will be done.
No, that is the problem. See, the problem is the patient has been admitted under the wrong team. They are aggressive, but they don't know what they are doing. They just do all investigations instead
No,
of.
Nikita, commonly, see, there are so many uncommon things which can happen. But me and sir were discussing, if the patients present to you with that picture, there is no need to repeat MRCP or do MRCP or repeat LFT within like 24 hours. Once you have the clear picture on CT and with the ultrasound and the LFT which you had. So you have gone in for a confusion because you have repeated and you've done an MRCP also again. And see, whatever it is there right now, if there is CBD, if it is clear, you straight away have to go ahead with surgery only. In this case, also, even if you're suspecting a malignancy. What did the MRCP say? Was there a gangrenous gallbladder or they suspected some CAGB?
There was breach in the wall of gallbladder, sir. It could be either abscess, but they were thinking it could be secondary due to some liver malignancy, like hepatic malignancy. To rule out, they want a contrast study.
No, either way, even if you do contrast CT, they cannot be clear. So when
Yes,
they
sir.
have suspected that there is a breach in the gallbladder and probability of abscess is there, and LFT with the malignancy, it cannot rise so much in one day.
Yes, sir.
It either has to be some kind of an infective pathology or sepsis which is going on, or if there has to be an obstruction in the CBD.
So the root of confusion is patient is admitted under a department where they are not used to regularly handling these kind of cases. So they just do all investigations available. So that is the problem. As Niranjan said, with one LFT what you had and the CT report which suggested gangrenous gallbladder with perforation, you should go ahead and operate on this patient. And at the same time, if for example, if you see a lesion in the liver, then you take a biopsy of the liver. So that is very clear. Okay. What was done?
We went ahead with laparoscopic cholecystectomy, sir, after MRCP. So there was a gangrenous gallbladder with pus was filled internally, sir. It was pouring out, as you can see in the second image. After cholecystectomy, we looked into the GB fossa, the whole liver surface. We pressed onto the liver surface also, sir, but we couldn't see any point of pus coming from the liver. So, sir did not want to aggressively try to manage what the liver has. So, we just came out. We put a drain and came out, sir.
Okay. Now, what you have done is correct. Looked at you've taken the gallbladder out. You looked at the gallbladder fossa. You looked at the liver as it is, as it appears. Okay, and you drained the pus and everything. If, for example, was the patient stable? Was there a lot of bleeding?
Sir, because he was on clopidogrel and all, there was bleeding, sir, like significant. He was oozing from all the areas.
significant bleeding was there. Was the patient stable or unstable?
Patient stable, sir.
Stable, sir.
Not to that extent, sir, but
So now, if for
You cannot say
example,
not to that extent. You can say whether patient is stable or not stable. When somebody asks you in the exam, you cannot
no,
say
sir.
not so stable or not so this thing.
Bleeding was not to that extent which caused him to be unstable is my line, sir. I'm sorry, sir. Bleeding was not that severe, but there was oozing from all over the liver surface and the gallbladder fossa, sir.
okay. Now, if the patient is stable, there is a lot of confusion about the diagnosis. There is a perforated gallbladder with pus in the gallbladder. So you have done what is right. That was to take out the gallbladder. Is there anything else you want to do, or you want to wait for the, for the patient to recover and then, clear this confusion? Nitya?
There is
Sir, I wanted to wait and then uh, what, sir? Especially for the malignancy part, I think I would wait because right now the patient is having oozing everywhere. It's better not to take any biopsy, sir.
That is one thing. Second thing is,
sir, intraoperatively we can do an
anybody,
ultrasound.
you only, Nitya.
Mm,
Correct. See, the thing is, what Nitya said is right. See, the previously, when the amoebic liver abscess used to mimic hepatocellular carcinoma. Exactly. So, the liver abscess could potentially only be liver abscess. It is difficult to, at this stage, you know, see, differentiate whether it was a malignancy or abscess. And as you said, the patient is, elderly, is on clopidogrel, he's had a difficult cholecystectomy. There was pus, obviously, there was gross, pus was there inside the gallbladder, and it was oozing from the surface of the liver. So, having done all these things, probably safer to, close the, finish the surgery, wait for the patient to recover from surgery, then investigate if, after the patient has settled down. Probably that would be my, this one train of thought. Niranjan?
Yes, sir, same. And also, even if it is malignancy, you will come to
Ultrasound
know
if it
about
is
it, and
available, and then do a biopsy of the liver.
even if it is malignancy, you would have come to know by doing the gallbladder, like you have done cholecystectomy. Without
Correct.
involvement of the gallbladder, there cannot be that malignancy based on that picture, whatever it is there.
Yeah,
So
correct.
you will get the answer on histopathology. So also wouldn't do anything more here. I'll just keep a drain and come out. And probably if patient is spiking fever or something, not settling down, rising counts and all that, then I will probably do a repeat CT and say probably CT guided aspiration of liver abscess if it is there.
Yeah, I think so. Nikita, the answer to your question is that you said you were going to do intraoperative ultrasound. Yes, that is definitely a possibility, but here you have to look at the whole picture and then say one patient is 75, elderly, diabetic, ischemic heart disease, clopidogrel, all these things, and it was an emergency surgery. No advantage to be gained by trying to do, prolong the procedure. You have done what is right, taken out the gallbladder, washed it all out, put a drain, come out. And anyway, your management is not going to change. If it is malignancy, then his goose is cooked anyway. So, you only want to prove the histology. And as Niranjan said, it's whether it is hepatocellular carcinoma at the bed of the gallbladder, or so an adenocarcinoma arising from the gallbladder itself with perforation and abscess. You would get it in the histology when you send the gallbladder for biopsy. So you don't have to worry about getting the histology at the present time. I think present time is to get him off the operating table and get him better. Okay, so what
Yes.
happened? What happened post-operatively?
Yes, sir. Patient, sir, drain output was there, sir. Eventually on POD3, we removed the drain and patient was discharged, sir.
What is the biopsy for the gallbladder?
Sir, acute cholecystitis features only, sir.
Cholecystitis only.
No
Ah,
evidence of malignancy.
Mhm.
okay.
So there was a CT repeated on around POD4, sir.
Ah,
That showed there are small pockets of collection, probably liver abscess in the same segment.
ah.
but it could be conservatively managed with antibiotics because we already had the pus culture of the previous thing, sir.
Okay. So it's unlikely to be malignancy.
Yes, sir.
I think it will be safer to do once the patient recovers, you do CA99 and CEA and alpha fetoprotein
Yes,
just to
they
give.
were
It
sent,
is
sir.
done.
Uh,
They're
Initially,
not,
when we were suspecting the neoplastic etiology, on the day one only they were sent, sir, before surgery.
all of them are
Uh,
normal.
they were normal, sir, within limits, sir.
Okay. Anyway, it may be safer to repeat it after once the patient has fully recovered. Sometimes in the presence of acute inflammation, you may not get the proper picture. If you want, you can repeat the CA99 and alpha fetoprotein. If they are normal, you don't have to worry. You can even get a CT done 1 month later, 2 months later to see whether the patient has um, the whole thing has resolved and it is better now. So Ainas, you've been silent. What are the lessons from managing this patient?
So first is like when we have the ultrasound and CT showing the initial investigations were what we should look at and then plan our management instead of repeatedly going ahead with the different investigations. We should deal with like the perforated cholecystitis was the main problem, especially when the patient was diabetic, sir. So we should address that and then go ahead once the patient stabilizes to consider dealing with the liver abscess or the malignancy part, which was a question, sir.
Okay.
Yes.
Right. I think the main thing is that probably the patients do better if they get admitted under the right people, because there will be no confusion, because we have clarity in what we, as Niranjan said, patient comes with these investigations and the CT and ultrasound report. It is very clear. So there is no need for further investigations because it will just muddy the water and make the picture very unclear. So go ahead with the surgery, and then once the patient is recovered, then you can investigate the patient. So there is no problem,
And you do investigations only if it changes your management.
management.
When it is
Correct.
not going to change your management, you should not be keep on doing unnecessary investigations, keep on dragging it. And in this case, why was it admitted under nephrologist? There was no CKD, nothing.
I don't
They
know.
were
That's
known to, sir.
Okay.
Like
Niranjan.
he was regular.
This surgery was done on the Sunday, right?
Yes,
Nikita?
yes, sir.
Yes,
Yes,
sir.
sir. Yes, sir.
Niranjan, would with this picture, patient on clopidogrel, patient is not septic or tachycardic or anything. Would you wait for another day and do it on a weekday, or would you do it on Sunday itself?
If patient is very stable, and there is no signs of sepsis with respect to clinical as well as biochemical parameters, I probably would wait.
Correct. I think that is the another thing, another learning point. Yeah, sometimes physicians may bully you, but you can tell them that it is better to do it on a weekday, and especially as patient is on clopidogrel, it will cause bleeding and everything. And this clopidogrel bleeding will not stop with all your FFP and everything, because it is qualitative platelet is that is affected by clopidogrel and aspirin. So you maybe giving another 24 hours also will help. If the patient is septic, patient is toxic, patient needs ventilator and all these things, tachycardia, hypotension, certainly you have no choice but to operate. But if the patient, as Niranjan said, patient is stable, there is no rush of doing it on a this one. And even financially, on a Sunday it will be more expensive to the patient also. So I think you can politely tell the physician, I think we'll prepare the patient, and will clopidogrel is there, so we'll do the surgery next day. That is the learning point in this case. Okay, next case.
Yes, sir. The next, the 91-year-old male with complaints of abdominal pain post the ultrasound scan, sir. The pain was continuous in nature with no radiation, not relieving with medication, not associated with food intake. It was aggravating on cough. Patient was admitted in view of decreased appetite, weakness, and altered sensorium. He was a known case of hypertension and benign prostatic hypertrophy on medication. Patient underwent right inguinal hernia with no known allergies.
Okay.
His general examination was within normal limits, vitals were normal. Abdomen on examination, there was tenderness all around with guarding, and bowel sounds were absent. And local examination revealed right groin scar.
Sir, sorry, I was in a call. Oh, is it some other case?
Yeah, second
Yes,
case
sir.
now.
Okay, okay.
So the learning points, I think what I concluded was one, as Aina said, the patients, if they get admitted in the right department and with the, with the focused investigation that we had, which clearly showed that the ultrasound scan and CT scan showed presence of, gangrenous gallbladder with perforation, no further investigations were required and patient should be operated. And in view of the fact the patient is relatively stable and there are no evidence of toxicity or evidence of peritonitis and patient being on clopidogrel, it is fairly reasonable to postpone the surgery by 24 hours, especially because it was on a Sunday, and do the surgery on Monday. So that those are the two major learning points in this case. Okay, the
Yes, sir.
second case is a 91-year-old man who got admitted under the physicians with abdominal pain and investigations showed clinically he was tender with guarding and rigidity, and investigations go on.
Yes, sir. Lab parameters were there was a picture, UTI picture was there, sir. Otherwise, blood reports were within normal limits, and they had done an ultrasound which showed terminal ileum and ileocecal wall thickening with right iliac fossa lymph node enlargement, with no significant free fluid, sir.
Okay. So, Nikita, with this finding, what are you suspecting? Or should Praveen answer that question? Praveen.
Based on his symptoms, it's looking
And
like
signs.
signs.
And ultrasound picture.
Yes, sir. Based on symptoms and signs, he has features of peritonitis, sir.
Okay.
But ultrasound is not showing those. So
Ultrasound shows,
there is
thickening of
thickening,
the ileocecal
but
region
yes, sir. But
and
they
multiple
did not.
lymph node mass.
Yes, sir.
So, what are
But
the
those
likely
are all
possibilities?
suggestive of infection or inflammation. But they did not mention about any abscess collection or perforation.
No, but what is your impression? 91-year-old man, in that order, what are the possibilities?
Due to age and signs, he might be in peritonitis due to perforation with sealed off perforation,
Yeah.
and
Due to what?
most common India is TB, sir, infective pathology.
At that age, tuberculosis or something
That
else?
age is not malignancy is common, sir.
Yeah.
91
So
years.
you have to first give differential diagnosis of thecal or terminal ileal malignancy. Second, of course, is tuberculosis. Third, what they have said about lymph nodes and everything. What could it be?
Diverticulosis, sir.
Why diverticulosis? Why should it cause
Perforated.
lymph node, man? Why should it cause lymph nodes? There is lymph node mass also. What is the other common thing that can happen? Nikita?
So, intestinal lymphomas, sir.
Correct. Lymphomas. So in that order, malignancy, tuberculosis, lymphoma, those are the three possibilities. Anything else? Nitya, anything else could it be there?
Crohn's inflammatory, I mean, can it be Crohn's
Inflammatory
second?
Crohn's
Crohn.
disease, inflammatory bowel disease, very rare at that age, presenting directly at that age. See,
Yes.
the inflammatory bowel disease, Crohn's, second to third decade, and there is a small peak in 6 to 7 decade. Very unlikely, with no previous history at all, patient
Mm.
at 91 presenting with inflammatory bowel disease. So that you could usually discount, but you can consider it, of course, but you can easily discount that. What else can be there? What is the common
So,
thing that we operate on?
Appendix.
so can it be intestinal?
Ah, no, appendicitis, whether it is appendicular malignancy, appendicular whatever, at that age you can't put it as first diagnosis, but you should consider appendix also. Number 4, Niranjan.
Yes, sir, I agree, sir.
So I think you should always speak logically. There is no, I may be right when I say this may be appendicular malignancy. I think it is appendicular malignancy. Even if I am right, in the exams I am wrong, because at 91 years of age, appendicular malignancy is not the common thing. It is usually cecal malignancy, ileocecal tuberculosis, lymphoma, and appendicular pathology. So these are the 4 possibilities you should think of. Okay, so Ainas, if you are faced with a patient like this, what will you do next?
Uh, Sir, we'll go further ahead and do a CT, sir.
So what are the
Like,
things that CT will tell you, what the ultrasound hasn't told you?
so first, it has not told us anything about, sir, like signs of perforation, sir. Like, if there is any perforation, if it is, at what point it is. It's also
Okay.
not told anything about the appendix as well, sir.
Hmm.
So those are the features which will help, like, tell us the main point of
Okay.
pathology, sir.
Now, right, Nikita, what other information would you get by doing a CT?
Sir, if any other collections, if present, sir, abscess, and also the lymph node status, sir, like what all the lymph nodes are
Mm,
involved and the size
Nikita,
and features
usually
of.
usually ultrasound cannot miss free fluid. So rather than looking for an abscess, you want to look for the like status of the bowel
Yeah, I
and
think
the right. So that should be your first answer rather than looking for abscesses there.
so. I think what Niranjan said, characterization of the lesion. See,
Okay.
ultrasound has just said something. CT will give you a much clearer picture, whether it is what kind of lesion that is, what is the extent of the lesion, and what is the relation to the
Location.
surrounding structure, all these things. Hello,
Yes, sir.
class class ತಕ್ಷಣ ಮಾಡ್ಲಾ ಫೋನು? ಹಾ ಹಾ, ಓಕೆ. ಹಲೋ ಹಲೋ.
Yes,
Yes,
sir.
sir.
Yes, sir.
Sorry, I got a call. I had to just take the call and just cut it off. So the CT will give you first the better idea of the origin of the pathology and the characterization of the pathology, the its relation to surrounding structures and what is happening to the, for example, ureter and all these things. Liver, give you information about the liver. It will also, and as Niranjan said, ultrasound will always tell you if there is a abscess or fluid collection and everything. Maybe the CT will give you, as Aina said, presence of perforation, and it will also give you more, more characteristic picture of the lymph node mass that is there. And then, any other pathology that is there, in the status of the kidney, the liver, and all those things. So I think CT will be definitely a better investigation. What did the CT show?
Yes, sir. The CT showed moderate free air in the peritoneal cavity, hollow viscous perforation likely at ileocecal junction, and terminal ileocecal thickening, sir.
Okay. So with this picture, what will you do? Considering the age of the patient and everything, what will you do? Praveen?
Then first we'll see whether the before the admission whether patient is active or bedridden. What is the
Yeah.
status of his condition, sir?
What was
he's
the status
active-
of this patient? What was the
Sir,
status of this patient?
Sir, he's
Healthy, active,
walking,
sir.
talking, and he
Active.
carries out his usual work on his own, sir.
Correct. What was the only problem that you were worried about? What the relative said? You worried about his nutrition because for the last 3 to 4 weeks, his oral intake was virtually very, very poor, virtually non-existent. He was not eating anything at all. He didn't have any appetite, and he ate very little. So, and he probably lost significant amount of weight. So that is one thing. But he was very independent and active. So that is the thing. So with that picture, what would you do?
Do a diagnostic lab and we'll do the resection anastomosis, sir.
See, when there is perforation and there is free gas, significant amount of free gas in a 91-year-old, what is the advantage of doing a diagnostic laparoscopy? Because you got all the information that you want by the CT. Is there any advantage doing a diagnostic laparoscopy?
Then any other perforation sites?
Yeah.
Apart from
So yeah, you will
the
get to know the
mentioned in the-
site of the perforation. Okay. What
Yes.
other information you may likely to get that you may
What
consider?
is the other main advantage of doing laparoscopy? If patient is fit enough for laparoscopy, especially in a case of perforation.
Mobilization of bowels will be easier in lab, sir.
Sorry?
Mobilization of bowels.
No, not mobilization of the power. It will not be easier in laparoscopy when there is so much of peritonitis and all that. What is more the advantage of doing laparoscopy? So the
If it
peritoneal toileting and lavage can be done in a far better way in laparoscopy than in laparotomy because you can target all the four quadrants, wash out thoroughly, but repeated washes you can give. Because in laparotomy, if you do a lower midline incision or whatever, transverse incision or whatever, you cannot reach all the areas effectively when compared to laparoscopy. That is one more advantage of doing laparoscopy.
Yeah.
If patient is fit enough and stable enough.
And if it is only a pinpoint perforation, sir, we can just do laparoscopic suturing of the
Yeah,
No,
correct.
but
repair of the perforation.
yeah, but
If
here there was lot of gas in the thing, and there was a large mass on the CT, so it's unlikely to be a pinpoint perforation,
yes,
right?
yes, sir.
Yeah.
Oh, mass, I didn't read. CT report, whatever
CT
he has
image.
put it up. Was there a mass?
Yeah, ultrasound itself had said a large mass in the ileocecal region.
Okay,
Thickening
okay.
with mesenteric haziness and kind of mass formation picture was given, sir.
Okay, okay.
These were
No,
the
no.
points mentioned,
CT
but
report,
verbally we
whatever
got
he has put
explained.
it up, so it doesn't mention mass. That's why I was telling
Yeah.
about laparoscopy. Yeah.
So here we did consider laparoscopy, but unfortunately, finances, of the patient, they were supposedly CGHS, but they didn't take up CGHS. They said CGHS patients are not being now admitted, so they were not keen on the cost. They had to keep the cost down, so we straight away went for a laparotomy under epidural. I think other advantage was he had tachycardia and he was elderly man. So
Yeah, yeah, yeah.
we wanted to make sure that we one more system didn't get added to the morbidity. So we did it under epidural. So lower midline incision. Okay. So patient
Okay, go on.
finance,
What was the
unfortunately, patient finance definitely plays a role here, and also the hospital admission policy in terms of CGHS and all that, which we have discussed now. Okay,
Yes.
so findings.
what are the findings?
Yes. Sir, there was a ileal perforation about 1 feet from the ileocecal junction with multiple mesenteric lymph nodes along the middle colic and the ileocolic vessels. And we went ahead with resection anastomosis of ileum to transverse colon.
What? I didn't get you.
Sir, ileal and transverse colon anastomosis, sir. Like resection
Right
anastomosis.
hemicolectomy.
No, you said
Yeah.
the perforation was in the ileum, not terminal ileum.
Terminal ileum,
Millimeter away.
1 foot from the whole terminal ileum till there was very inflamed and thickened, and the perforation was 1 foot from the ileocecal valve. The whole ileocecal region was very hard, and it was in a large mass going up to the hepatic flexure. And
Okay.
so when we were mobilizing, first when I opened the hepatic flexure region, Sanya and Nikita said, "Sir, you opened bowel." It was not bowel. We just opened the along the white line and mobilized it from the liver. And then the vessel in the ileocolic vessels were so huge. When I was showing it to her, she said, "Sir, there is bowel there. You be careful. Don't open that." I said, "That's not bowel. You will not get bowel in the mesentery. It is very thickened and very dilated ileocecal vessels." Anyway, and there was huge mass near all the way up to the root of the mesentery. And when we ligated it, and there was a little bit of opening of that lymph node mass, and it started oozing pus. So then we realized that it probably is likely to be tuberculosis. So we did a standard right hemicolectomy because the whole thing was extending up to the hepatic flexure. Otherwise, I would have considered doing just a limited right hemi, but we did a standard right hemicolectomy, and the vascularity and was all very good, and patient was stable. There was no bleeding, so we did a ileocecal resection anastomosis. Nikita asked a question: should we do a stoma? Nikita,
Yes,
should we
sir.
have done a stoma?
Not required. The rest of the bowel appeared healthy.
Yeah.
There were
And
some minor nodules. Yes, sir.
patient was not unstable. There was no hypotension and significant bleeding and all these things. If intraoperatively the conditions are not favorable, see, definitely the story about not eating, we only came to know after the surgery. Another relative came and said that. Otherwise, we didn't know that. But still, if the patient was unstable, hypotension, inotropes, severe tachycardia, and he's a 91-year-old, we need to get him off the table quickly. Yes, certainly at that time we should definitely consider a stoma. Right-sided colonic lesions, usually you don't need to consider stoma that seriously, because the ileum has always usually very good blood supply, and the blood supply of the right colon is also fairly standard and fairly good. Only the left colon, what happens is the blood supply is quite sometimes dubious, sometimes unpredictable. The left colic artery may be absent, and it all depends on the left branch of the middle colic and the sigmoid vessels and all that. So what happens is the artery of Drummond, the arch of Drummond on the left side is fairly unpredictable, and we say that the critical point of Sudak and all these things are there. So on the right side, so no such problems are there. And then you are anastomosing ileum, which is got very extremely good blood supply, and it is not a watershed line between the superior mesenteric and inferior mesenteric, which can happen with the left side of the colon. So there is no such problems, and if the patient is stable, you can safely anastomose at that at this juncture. If the patient is unstable and if it is left-sided lesion, you certainly don't consider anastomosis, especially in the middle of the night. You straight away give them a stoma. Niranjan, hello.
Yes, sir.
Anything to add?
Nothing, sir. Same.
Nitya, any questions? Any difference of opinion about whether we should have done a stoma or whether we should have anastomosed?
Sir, generally, I was not there in drop, but whenever there's a perforation, there would be a contamination in the
No,
field.
there was no contamination. There was no contamination. No, there was
Okay.
only minimal amount of,
Nitya, general dictum is if there is gross peritonitis and gross pus everywhere, and then you do a protective stoma because the wound healing and anastomotic leak rates are higher. But when there is no gross contamination, as sir said, and bowels are healthy, you need not do a stoma,
Okay.
and especially in a right hemicolectomy.
Okay, sir.
okay, so that is a specimen. Nikita, do you want to explain explain the thing?
Sir, the index finger is pointing out to the ileocecal junction, sir, most probably the appendicular region.
Yeah,
I is the ileal loop, sir. C is the
yeah,
cecum. The whole portion from the terminal end of ileum to the cecum extending above was very hard.
yeah.
We did not cut open, sir, but the whole region was inflamed and hard, sir.
Okay, right. Carry on.
Yes, sir. This will be the last case. 31-year-old female came with difficulty in breathing and multiple episodes of loose stools to emergency. Patient was actually operated on 13th January, emergency LSCS in outside hospital. And in 16th January, she developed tachycardia, tachypnea, and hypotension, and was shifted to our hospital in view of ICU requirement. She was in one case of hypertension, gestational diabetes mellitus, and hypothyroidism. And surgery, I said, was emergency LSCS 3 days ago. No known allergies. So reference was given to us in view of the LSCS wound, sir. Local examination of wound which revealed gross pus discharge with extensive induration and fat necrosis. So
Okay.
this was the wound picture when we had got the reference.
Praveen,
Samir, why are you saying fat necrosis looking at this picture? How can you say fat necrosis by looking at this picture?
Sir, induration, sir, severe.
yeah, but no fat necrosis, no?
No, looking at the picture, how can you comment on fat necrosis?
Sir, the discharge was this
No,
lipolysis.
that will be there. Lipolysis. What do you mean by lipolysis discharge?
The
You cannot comment on fat necrosis
Yeah,
until and unless you see it.
yeah.
Here, there is necrosis of the skin.
okay, sir.
So, Nikita and Praveen, what are you very worried about in this patient? Looking at this picture. If I show this picture to you, what are you worried about?
So
What is this
the
condition called as?
gangrenous patch, sir, over the trachea.
Yeah, but
No, what is abdominal wall gangrene? That what is it called as?
what?
Foundation, sir.
Not wound dehiscence. There is no dehiscence there, man. It's clean. Wound is there. It is all. Nikita, Nitya, what are you
Melanie,
worried about?
Melanie's ulcers, the gangrene, sir, basically.
Melanese gangrene, correct. So, what could be the cause?
Because of obesity and the fat and dead space, like because the subcutaneous, they wouldn't have closed properly, sir. So the infection would have led to
But
No, no,
why
no,
are
no,
you
no.
beating around the bush?
How is it improper closure leads to Melanese gangrene? It will lead to wound dehiscence.
this is the
What is this
center of that.
condition mean? We keep on talking about this. This is a polymicrobial infection with the morbidity and mortality of between 50 and 70%. What is it? If it happens in scrotum, it is called something.
Fourni-
Necrosis.
Necrotizing fasciitis.
yeah, so
By
necrotizing
reference.
fasciitis. So,
That
what
is
could cause
something.
necrotizing fasciitis? Here, post cesarean, what are the possibilities? That's what I'm coming to. So, one, it can be a severe infection. What
Confirmation.
could have led to that infection if there is such gangrene and all that?
Contamination, sir, like during
And patient had tachycardia,
improper
tachypnea. No, sterility is one thing. That okay. What apart from sterility? They've done a
Diabetic status
This is a
and
they've
gestational
done an
diabetic.
Just is
no, diabetes is one, uncontrolled diabetes. Okay, that is again infection. Apart from infection, what else can cause? If there is any inadvertent bowel injury,
Okay, sir.
Yeah.
Contamination from inside. Yes.
yeah, because patient has developed tachycardia, tachypnea.
See, the two things you have to consider here is wound infection with deep space infection and necrotizing fasciitis. So the wound infection with deep space infection goes with what Niranjan said, possibility of bowel injury, or it is just a very severe form of
Necrotizing fasciitis.
necrotizing fasciitis because of a very virulent organism. So those are the two possibilities. So how will you deal with this, Nikita? Quickly, time is up. How will you deal with this? You are the person, they have given a reference to you. You are the surgeon in charge. Nikita, are you there, or are you just gone silent? Hello? Nitya?
Sir, I would take this first. I will stabilize the patient and needs debridement, sir. First, we need
Yes.
to let out the suture and the collection, whatever is there. It needs to be
What
drained.
what would you do first? You said stabilization, you give them oxygen, you give inotropes if required, put the patient on ventilator if required, and give
Antibiotics, yes,
fluids.
late.
But what is most important before you take them to OT?
I would take us culture and
Where
uh,
culture, ma? Culture later. But what is more important? Patient is very sick. Somebody
mm,
said that word, but no, it needs to be a bit more clear.
re-exploration.
Huh?
Re-exploration, sir.
For Adik Munchema, you have to do something, no? You said somebody said antibiotics.
What antibiotics?
You have to hit them hard, hit them, with,
Broad
broad
spectrum.
Broad
spectrum.
spectrum antibiotics.
yeah, broad spectrum, very high, antibiotics. You can de-escalate later if once you get the culture report, but first you have to hit them hard. So give them broad spectrum, higher antibiotics, then stabilize the patient, and then they take them to OT. Nitya, if you are the surgeon, what will you do?
Sir, first I would debride the let out, open out the sutures and then drain the pus completely.
No,
And then,
where will you open the wound?
sir, the sutures that is already there.
No, where will you open? The sutures are there. I can see that.
Yes, sir.
Huh.
First in the
Where will you
midline,
open the wound? Where will you open the wound?
the mid one, the center one, from which is closer to the necrosis, sir.
No, 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 no. This is why I wanted you to fall into the trap. You have to open the entire wound. No short, this short cuts here. You have to open the entire wound, because I knew you would say that. That is why I asked that question. No, open the entire wound and then
And there has to be a radical debridement.
radical debridement.
No.
See, you will get only one chance with these people. If you don't, then they will suddenly go down very rapidly, and then you can't do anything about it.
Okay, sir.
So do a radical debridement, remove all the dead tissue, and even, for example, open the the not just the skin, but the rectus sheath, which they have this one also. And as Niranjan said, we have to rule out the possibility of bowel. So open that also, unless it is absolutely clean, which is unlikely. Then you open that also, ensure the bowel is all healthy, and you can even leave the wound open, or you probably should leave the wound open, and or consider putting a vac in this situation. The after radical debridement, put a vac on that and wait for 48 hours before or the first application of vac, which is 4 to 5 days, and then consider secondary suturing if the vac has done its job. Niranjan, anything to add?
Nothing, sir. Probably if patient is stable enough, I will do a CT. If not, as you said, I will go ahead with the same thing.
Yeah.
So to rule out bowel injury, if patient is stable, we can do a CT, pre-op CT.
Yeah, yeah.
And also
Pre-op
to
CT can.
ascertain the level of this thing infection, whether it is going into intra-abdominal or is it only in the abdominal wall.
Yeah. So Sameer, you understood now the difference between this could be potentially wound infection with deep space infection, or it could be necrotizing fasciitis. These are the two possibilities. So what Praveen, have you operated on anybody with necrotizing fasciitis? 4 years gangrene, I think.
Funis
Ah.
gangrene done, sir.
So what is the the characteristic feature when you open these patients?
Will it be foul smelling with necrotic?
Absolutely, putrid, foul smelling, and
Putrid foul
what
smelling.
and what is that called? The pus will be what?
Dishwater pus.
It will be
So
watery. It will not
watery
be
pus.
thick pus that you usually see with wound infection. It will be like dishwater. Be foul, very foul smelling dishwater. Very thin and watery pus. So that should actually make you think. See, when you operate on such people, you have to have no mercy. You have to very radically debride it. Otherwise, you will end up losing the patient.
Yes, sir.
So that is one. Or if it is, frank pus, very thick pus, then you have to think about it being a deep space wound infection. So you have to explore till the level you have reached where the wound looks very clean, and drain all the pus and irrigate the whole cavity nicely. And for the time being, pack it and come out. And later you can apply vac dressing on that and wait for 4 to 5 days till the first application of vac is done. Once you take it out and see how the wound is, then you can either consider putting another application of vac, or you can secondarily suture it. Okay, so I think that is probably sufficient. We have had 3 good cases, 3 discussions. Any questions, doubts on this?
No, sir.
No,
But
sir.
third case, the probable cause for the infection would be, sir,
Which one?
in the
This
LSCS
third case.
case.
See,
Hmm.
as we, I think Niranjan asked that question, no? So
Yes,
the
sir. No.
What was done? What
possibility.
was done in this case?
What was
So
done?
we planned for the debridement, sir, and
Ah,
debrided all the necrotic tissue. Then we did resuturing, sir.
Resuturing.
Yes, sir.
immediately.
Yes, sir.
Why? It was such extensive this thing, and I don't think the skin would have come that this thing. Why
We
was the
did,
hurry for resuturing?
sir, from the patient side, there was this pressure because they were considering it as a mismanagement due to the previous operating surgeon.
No.
So
Whatever might be the pressure with such necrotizing this thing of the skin
the
and such a
complete
large area.
necrotic patch was removed. So minor paniclectomy was done here, and we
Ah,
got the freshened edges which without any infection.
No, but
Like
again, if you close the purpose of doing that drainage and necrosis is in necrotizing fasciitis, there should not be a hurry to close the wound. It should
so
always be left
ideally
open, either through a
vac was
vac
advised.
dressing. Yeah.
It was advised, but
See,
they were
in this
not
picture
willing, sir.
also, there is lot of pus still there,
Yes,
yeah.
sir.
and the
Yes, sir.
skin edges are
Before
still
debridement.
necrotic.
And wound
Skin
doesn't
edges are
look
also
that
still
clean,
necrotic. Yeah.
pale, and
So if
probably
you close in this scenario, there is high likelihood of wound infection spreading further than improving in such a scenario. Whatever might be the
We
pressure
had
from
to
the
drain, sir.
patient.
see, you have to do the right thing. You should tell them, see, it is not the fault of anybody.
No,
These things
Nikita,
happen.
just putting a drain will help in only draining the pus. But what about the necrosis? initial pathology, this thing will remain the same, the infective pathology. If it necrosis or if the necrosis spreads again, then you have to take the patient again for redebridement. Then how will you explain and this thing? No, how will you answer the patient attender? The same patient will attender will come and ask you like somebody else will come and ask you, why did you close with such a sepsis,
Sir,
localized
agree, sir.
sepsis?
We actually informed them about the back dressing and all as the primary option. They refused for it, so they were asking for the uh, closure of the wound. They didn't want to manage it further. So we it under explained risk that it might recur again. There is a high chance because currently infection is still there. What we are trying to do is minimize the infection. We'll try with antibiotics, but if it recurs, we will plan for a re-exploration. Was already explained to them, sir. So, as their autonomy, we went off ahead with the second option. But even patient attenders are clear that this is the second option.
So now, how is the patient?
Wound wound line is healthy, sir, but from the drain there is still pus discharge. There are no
What
evidence of. Sir,
is the patient in ICU or is the patient in ward now?
patient was in
Yes.
ward, discharged, sir. Patient right now on follow up in OPD. Today it would be around POD 5, sir. They had come for 2 follow ups.
Hmm.
Wound looks healthy, sir, as of now,
And
but pus
what
discharge is
was the
still there.
level of infection?
Up to the
Sir,
sheath or up to the sheath or
almost up to the sheath, sir. But there was no breach up to the sheath.
okay.
So it was only skin and subcutaneous infection.
Yes, sir. Yes, sir. No deep organ infection.
Okay. See, the thing is, you should know exactly what is the right thing to do. Here probably right thing has not been done due to extraneous pressures. That's different. But you should
And
not give this
one thing
answer.
you people should remember is, you first of all, even in exams, you should not answer like this because of the patient pressure. You did that, and second, legally also there is no explanation to say that you did it because of patient pressure. There will be like legal implications if the same patient goes to court, if there is repeated infection or if the infection spreads further, and you have to redo again. So there will be no protection for you for you, even if you have documented and done that, saying that patient insisted on that.
See, the patient will say, I didn't know the implications. They just,
They didn't explain it to me
yeah.
properly.
So then you will be in trouble. So that is why it is always better to do the right thing. Anyway, so what the right thing is. We have explained to you the two possibilities and what you should do in each of these possibilities. Okay. Any Nitya? Any questions?
Even if you wanted to close without vac dressing, ideal thing would have been to leave the wound open, do dressings for at least 48 to 72 hours, and then go for a secondary closure later.
Yeah, that's
Once you're
what
sure
I
that
said. Yeah.
the wound infection is not spreading, even if they were not willing for vac.
Agree, sir. They were not willing for that only, sir. Like we daily dressing
Fine.
or
Okay.
vacuum dressing
No,
Yeah.
was
no.
advised.
See, you
Yes,
understood our point, no? What
yes,
we are
sir. Yes,
trying to
sir.
tell. Yeah.
Sir, but in case if they're still not willing, even
That is what.
documentation
Still not
really
willing,
won't
you
help, sir.
document, you just do the debridement, leave it open, even if they don't want vac. And after 48, 72 hours, once you're sure that it is not spreading, you go and close it with a drain.
Yeah,
Okay,
yeah. I
sir.
So
think
that will
that
be
is
safer.
Okay,
that
sir.
is that is the safest thing to do. You debride the wound properly and pack it and leave it open and just put a ioban or whatever it is, and then for 72 hours later open it and see how the wound is, how the infection is, and then further debridement and maybe then secondary closure with a drain in place. So that is one option.
Yes,
The other option is, proper debridement. Next day, put a vac. After inspection of vac for 4 to 5 days later, if the wound looks clean and healthy, you can do a secondary suturing. Otherwise, another application of vac. Okay. So you should know what is the
yes.
right thing to do. Okay. So Niranjan, final comments.
It was good discussion, sir. All the three cases were interesting and good.
So I think you should all, Niranjan. Thank you for being there. I think a lot of good points came from you. The important thing is that whenever you are faced with these kind of situations, you should do first of all what is the safest thing to do and what is evidence-based right thing to do, rather than succumbing to pressures from other quarters and all that. So for example, if the nephrologist say please do surgery on Sunday, you don't need to do it. You can put your foot down and say, one, it is not safe, and second, it is more expensive to the patient. I will do it on Monday. So I think you should be a bit more firm than that. Okay. I think that those are the lessons that you've learned from this. I think all three cases were very good and very what shall we say? Taught us a lot. Okay. Good night, all of you.
Good night, sir.
Thank you, sir.